Good morning, and welcome to the 76th Presidential Advisory Council on HIV/AIDS Full Council meeting, day 2, some would argue 3. My name is Marlene McNeese. My pronouns are she and her. I currently serve as Deputy Assistant Director with the Houston Health Department, and I oversee our Bureau of HIV, STD, and viral hepatitis prevention. I also serve as one of the co-chairs of PACHA, and on behalf of myself and my other co-chair, Dr. John Weisman, we thank you for joining in with us again today, especially individuals from the community, both virtually as well as those in the room with us again today. Your voice is what we seek to hear and learn from, and our recommendations are heavily guided by your experiences and your input as well. I think it has been an exciting 2 days, beginning with the site visits, our informal day, where we had opportunity to get out and actually engage with community work that's happening in Baltimore, as well as right here in the district. And we learned from some incredibly passionate, competent, and really leaders in the work. So from Reach, I'm still in LA. Was that 6 months ago? I blame you, Leo. I blame you. And we followed up with us helping us here in the district as well as La Clinica. And I was talking with Erna Hughes yesterday, and I was remarking how moving it was to hear from them about the work and how they've engaged with all the partners and the businesses in the community to help with their reach and their recruitment. Incredible work. So I thank them for hosting us again. We are not a small group to host, and I know that can become challenging. And John and I have been talking about ways in which we might be able to divide that up and make it more manageable and more meaningful, so we can spend as much time with each organization as we move forward in visiting with them. And I thought yesterday was equally powerful. It began really with an incredible conversation with our federal partners about where they are in terms of their implementation of EHE. And I thought, based on what was shared, there's been some incredible successes, and we should spend a lot of time talking about what those have been with these investments, but also the work that is clearly still left to be done. So really looking forward to ongoing engagement. I won't circumvent our Ending the HIV Epidemic subcommittee, but I'm certain that ongoing engagement with our federal partners will continue as we work to, help understand their challenges and ways in which we can offer suggestions or recommendations about the way forward. I also want to remark on the powerful, what I thought was the bidirectional global domestic perspective panel. It was incredibly moving as well, with talks of community power that really stuck with me, as well as how much we can learn and the work left to be done in trans communities around the world, particularly with highlighting some of the issues going on in Uganda. So I appreciate all the panelists and presenters there. And then we really closed out our day, hearing from our community, as we typically do, the most important part of the work that we do. And so I was grateful. We had so many participants on the phone. We'll get the numbers after the meeting, but we had lots of engagement virtually. So I really, really appreciate those who really hung in there with us to offer up your experiences and offer up your questions and what was really concerning to you as you also move forward in the work where you sit and live. I, too, just wanted to say that we have a full agenda again today, even though it's a half day. So I am grateful that you all helped us stay on task and on time. So I will ask for that same level of diligence today. We have a need to just remind everyone to make sure that as you're speaking, please remember to project and speak directly into the microphone. It was very hard for some of our virtual participants to hear parts of the meeting, and it was hard for some of our guests in the back of the room. So just remember and even help your table mate, if you not nudge them a bit, to get into the microphone so that we can make sure that everyone can hear this valuable conversation. And we have added a break into the agenda, so we won't try to torture you the entire day. So I think right after the federal update from Dr. Chandler Redonda, right before we go into our panel on addressing HIV and substance misuse from a community perspective, right before that 10:30 panel, I think we will take a quick break. Okay, so if you can make note on the agenda for yourselves, so we will govern ourselves accordingly. And then finally, my last opening remark is just wanting to remind the council about our commitment to what we shared at the closing of yesterday, to have some follow-up on the conversation based on the presentation from Director Phillips and talking about molecular HIV surveillance and cluster detection and response. We're asking if, I know Stigma and Disparities Subcommittee has a meeting coming up, but we're really asking all the committees, when you meet, if you have some time added on your agenda, certainly preview and review what we've heard. And if you've got follow-up questions or comments, if you can lift those up from your subcommittee discussions, that would be very helpful. So when we come back and engage as a full council, we would have at least had some preliminary conversations in subcommittee, if everyone is clear with that and okay with that. And I see heads nodding, so that's how we will proceed. Again, just looking forward to an exciting day. Again, topic being heavily focused around substance use. And I'm hoping that we will learn from very seasoned and experienced, happy to say, friends of mine and colleagues, longstanding colleagues who have been doing this work successfully from the seats that they sit in. So thank you, and looking forward to today.
Thanks, Marlene. Good morning, everyone, and thanks to all of you in the room, but also virtually joining us. Marlene, I heard earlier, I think over 300 people had joined yesterday. If Caroline can give me the, yep, Caroline's saying, yep, over 300 people. So thanks for joining us for these important meetings. And just want to remind everyone, if you do have public comment you want to give, you are more than welcome to please send us an email with your comment at PACHA@HHS.gov. That's PACHA at HHS.gov. And if you get your comments into us by, I think it's April 5th, we'll be able to get those into our work. So thanks for that. I also just want to follow up. Did I introduce myself? Maybe did I? I don't know. John Weisman, co-chair, and you see his pronouns. My regular job is working at the University of North Carolina, Chapel Hill, Gillings School of Global Public Health as a professor of the practice, and honored to be able to co-chair with Marlene. Did want to just also follow up that as Marlene was talking about the follow-up on the molecular surveillance and cluster detection piece, that the Stigma and Disparities Work Group will be the lead work group on this. And we do anticipate following up with specific questions and follow-up information we would like to have, and anticipate asking for a meeting with Director Phillips and CDC as we do that. So just do want to reassure everyone that we are absorbing the information as well, and want to be very thoughtful in our continued engagement on this topic. So today we will be getting a number of updates on the White House from Director Phillips on HIV/AIDS work, an update on MPOX, and the blood donor policy update with Dr. Marks here. Pleased that we're going to be doing that in September. PACHA did a resolution around blood donor policy, and we're excited to get the follow-up on that today. And then we will move into our substance misuse and drug overdose pieces of the agenda as well. And then the council will have about an hour for discussion and reflections after lunch, and then we will wrap up by 2:30. And just another reminder, in case some of you sign off early, the next PACHA meetings are scheduled. June 27th through the 29th will be in Arizona, yet to be determined exactly where. September 19th and 20th, all of us will be virtual for that PACHA meeting. And then in December 5th through the 7th, we'll be meeting in Houston, Texas. So we are looking forward to seeing those of you out in, again, other parts of the country as we take PACHA to the people. And with that, I know today is going to be as interesting and important as yesterday, so we should move on with it and turn it over to Kay Hayes for our roll call.
Great. Thank you, Marlene and John, and welcome everyone. I'm about to start roll call, and I will remind our federal partners and PACHA members, when you introduce yourself, please state your organization or your federal agency. PACHA co-chair Marlene McNeese.
Present.
PACHA co-chair John Weisman.
Present, and just to get the sequence going,
Yes.
University of North Carolina, Chapel Hill Billings School of Global Public Health.
Great. Thank you. Greg Alton. Guillermo Chacon. Tori Cooper. Rania Copeland. Alicia Diggs.
Present, University of North Carolina at Chapel Hill Center for AIDS Research.
Thank you. Vincent Guillermo Ramos.
Present, Duke University School of Nursing.
Thank you. Jennifer Cates.
Present, KFF, the Kaiser Family Foundation.
Thank you. Mark Meacham.
Present, Vive Healthcare.
Thank you. Leo Moore.
Los Angeles, present, Los Angeles County Department of Public Health, Los Angeles, California.
Great. Rafaele Nevadas.
Present, Latino Salud, South Florida.
Laura Platero.
Present, Northwest Portland Area and Health Board, Portland, Oregon.
Great. Kayla Quimbley. Kayla Quimbley. Michael Sag.
Present, University of Alabama at Birmingham.
Thank you. John Sapero. John Sapero. Carl Schmid.
I'm here, and HIV and Hepatitis Policy Institute, Washington, D.C.
Thank you. Justin Smith.
Here, Positive Impact Health Centers, Atlanta, Georgia.
Thank you. Ada Stewart.
Present, Family Medicine, Columbia, South Carolina.
Thank you. Daryl Wheeler. Daryl Wheeler. And our CHAC liaison to the PACHA, Wendy Armstrong.
Present, Emory University and Grady Health System.
Thank you. I'll proceed with our federal partners. Harold Phillips.
Present. Director of the White House Office of National AIDS Policy.
Thank you. Dimitri Daskalakis.
Dimitri Daskalakis, great question. MPOX, White House Deputy MPOX Coordinator, deployed from CDC.
Thank you. Adrian Shanker.
Present, Adrian Shanker, Senior Advisor on LGBTQI Health Equity, Admiral Levine.
Thank you. Alicia Richmond. David Johnson. Tim Harrison.
Present, Office of Infectious Disease and HIV/AIDS Policy.
Thank you. Sam Wu.
Present, HHS, Office of Minority Health.
Thank you. Jonathan Merman. Jonathan Merman. Robin Neblett Fanfare.
Present,
Principal Deputy Director, Acting Director, DHP CDC. Good morning.
Good morning. Heather Houck.
Present. Present. HRSA HIV/AIDS Bureau.
Thank you. Erna Hughes.
Present. HRSA Bureau of Primary Health Care.
Thank you. Timothy Holtz.
Good morning. Present. NIH Office of AIDS Research.
Thank you. Lee Fleischer. Jessica Lee. Rick Haverkate.
Present virtually, Indian Health Service National HIV Program Consultant.
Thank you. Kristen Roja. Rita Harcrow. Edwin Walker. Gerard Redevosian.
Present, Senior Advisor, Office of the Global AIDS Coordinator, State Department.
Thank you. And Peter Marks.
Present, Director of Center for Biologics, FDA.
Thank you. That concludes the roll call. Turning it back over to Marlene and John.
Great. Thanks so much for that. And again, really appreciate all the federal partners who are around the table, both in person and virtually. So next, we're going to move into very quick subcommittee updates. Much of the work that happens in between these council meetings occurs in our committees by folks who are looking at the material we received in our full council meetings and looking to follow up on various topics and move forward potential resolutions and other policy considerations. So with that, we have 3 subcommittees that in which we do our work. We're going to hear from each of them, and we will start with ending the HIV epidemic in the U.S. and the updated national HIV strategy with Carl Schmid leading that for us.
Great. Thank you, John. And John Shapiro couldn't be here today, our co-chair, so I'm going to give the report. So as I mentioned yesterday, the subcommittee has been bringing in different federal agencies to receive reports on their work. And as I stated yesterday, we first heard from SAMHSA, and then we heard from the Bureau of Primary Health Care to talk about their work with PrEP. And we did send a follow-up letter to BIPIC asking for more granular data on who is getting exactly who is getting PrEP in the community health centers, and we're looking forward to a response. I hear it is forthcoming. Also, we did PACHA leadership did meet with CMS, and that was an effort to, well, first of all, we did a invitation letter, request letter, and then they asked for a lot more information before we had the meeting, and we did have a very successful meeting with the administrator of CMS. And as you can see, it has partially paid off with CMS's participation yesterday, but I think and I'll bring this back to the subcommittee, but I think we would like to do a follow-up letter to have a true partnership. And it's not just, for us in the community and for PACHA, but I think it's for our federal partners as well. That CMS is just so critical, Medicaid, Medicare, the marketplace, private insurance, to every aspect of HIV prevention and treatment. We really need a true partnership with them. So I'm going to recommend that we do a follow-up letter. And I did have a side conversation with Dr. Fleischer about our request, but I would like to follow up with and it was good to see that they are doing some things. We are on their radar, but I think we really want a true partnership. And then yesterday, you could see our efforts of, bringing in 10 different federal agencies and all the work, the excellent work that is going on. It shows it's a collective, whole of government approach. And it wasn't every department, even our agency, involved with HIV. It will be interesting. I think we'll discuss, follow-up and what we would into some of the agencies. And one of the things I was thinking about is that we're getting piecemeal. We're hearing from this agency, this agency, this agency. It would be good to get national data. And so I talked to Tim about this yesterday, but maybe having a presentation on the AHEAD dashboard and what the numbers, how are we doing with PrEP nationally? How are we doing with treatment? How are we doing with prevention? And so that would be one of my recommendations for the subcommittee to hear, nationally, how we're doing, because we're looking at everything individually. Harold's going to be talking about the president's budget for FY24. I wanted to talk about how we did in FY23 because that's what's guiding what we can do this year. And the president did put forth, proposed increases. And in the end, Congress did not, fulfill what the president requested for ending the HIV epidemic. In the end, there was only a $100 million increase, split between $40 million for Ryan White, $35 million for community health centers, and $25 for CDC. I would note that Indian Health Service did not get any increase, even though it was proposed. And that was one of my questions yesterday for Rick was, they're doing all this work. They have this great, strategic plan, but do they have the funding to implement it? Other parts of the Ryan White program did get increases as well, $36 million, and Hopwood got a $49 million increase. PrEP is another major issue for the subcommittee, and the president did propose last year and this year a mandatory PrEP national program. It did not get implemented last year, and actually Congress did not appropriate any money for PrEP last year, except for the community health center work there. So I think that's something that that the subcommittee would like to follow up on, and maybe we could do a letter, is how CDC is, CDC can do more on their own. It's in their charter, it's in the law to do more on PrEP. So I think that would be one area, that we would like to focus on as well. And then finally, we did hear from public comment yesterday about the Ready Set PrEP program, the data collection, and we will take that up in subcommittee and get a briefing on that. So those are just some thoughts and ideas. Welcome any comments, and we will definitely be following up in our next meeting on many of these issues. Marlene.
Yeah, thanks for that, Carl. In terms of the federal response, we heard a couple of comments repeated yesterday about where are we with engagement with other departments federally, such as the Department of Labor, as it relates to employment concerns, as well as the Department of Education. And so I was hoping to ask you and that subcommittee to potentially look into engagement around that as it relates to some of the ending the HIV epidemic work. I just heard it a few times and wanted to hear some follow-up.
I think that's a good suggestion, Marlene. And I also saw that HIV.gov put out a report yesterday that from the Department of Justice on prisons and HIV. So maybe, we could bring in HUD was here yesterday, but some additional agencies next time we meet as well. When we talk this afternoon, I would like to focus a little more on the youth and education. That is a major area I think that we've neglected, and but that's for this afternoon. Did you want to say something?
I was going to say I'll also provide a little bit more context based in my updates this morning.
Mike.
Yeah, related to news items, I think that just to get it out there. One is you probably heard from the FDA yesterday that Narcan over the counter was approved, which I think will help an awful lot of people and save lives. And the second thing, I guess we can talk about this in the global report, but ViiV Healthcare entered into a generic agreement with several companies for international distribution of intramuscular cabotegravir for prevention.
Any other questions or thoughts for the ending the HIV epidemic subcommittee?
I don't want to create trouble, but maybe we should change there seems to be some confusion about ending the epidemic initiative, and just, we're here to end HIV. And I don't care if it's from an EHE line or a Ryan White line or whatever, but I think that's our goal. And there seems to be some confusion. So we have to correct that.
Okay. Next up, we have Global and Jen Kate.
Thank you. Hi, everyone. Sorry I can't be there in person. This will be a very short update on behalf of myself and Greg Alton, who also co-chairs this subcommittee. First, I want to thank all of the participants yesterday in our excellent panel on stigma. It was, and I think we would all agree it was really an exceptional discussion, and it was wonderful to get their time and thoughts and really contributions to this complex topic. Our subcommittee's work is focused on bringing a global perspective and an update on PEPFAR to each PACHA meeting, as well as identifying these opportunities for bi-directional learning. So much of our work is coordinated with the other subcommittees, as was yesterday. So that's the way we've approached integrating a global perspective and creating that bi-directional opportunity. We're also very pleased that a representative of PEPFAR is now one of the federal partners who attends these meetings. And we think that's another opportunity for all of us to make sure we're continuing to share those lessons and get those updates. Just very quickly, and I'd welcome other PACHA members' thoughts. Future areas we've discussed looking at with other subcommittees, addressing the challenges that women and girls face, looking at community and civil society engagement and how that is done both through PEPFAR programs, but also domestically, and what lessons might be there. An area I heard yesterday that I would love to explore more for bidirectional learning is Rapid Start, and what we can learn about what PEPFAR has done, as well as some innovative examples, such as the one we heard from New Orleans yesterday, and others. So we welcome your thoughts on issues that PEPFAR's experience could shed light on for our work. Thanks. And Mike, please feel free to add any other thoughts on this.
I think it's good.
Any other questions or comments for Jen in the Global Committee? Okay, seeing none, we'll go on to Stigma and Disparities with Raffaele and Justin.
Yes, thank you. Also want to echo my appreciation for our colleagues who joined us yesterday for what I thought was an exceptional global bidirectional learning panel. So it's also great to work with our partners in the global subcommittee on making that happen. So kudos all around for that. In the Stigma and Disparity subcommittee, we were fortunate to be able to have an in-person strategic planning meeting a couple of weeks ago, where we were able to really map out what it is that we want to accomplish for the year. And so I think just to kind of run down some of the things that we prioritized, obviously we will continue our ongoing work on molecular HIV surveillance. That's going to remain to be a priority for the subcommittee. So we will obviously stay focused on that. We've also adopted a technique from our colleagues in the HIV epidemic subcommittee, where we bring in partner organizations and federal partners to also give us briefings in our meetings as a way to make sure that we're keeping a focus on stigma and equity and other types of topics from our federal colleagues and other partners who have a perspective on that. So just to kind of, one of the things that we did during our meeting was map out and map our meetings to specific topics. There'll be some wiggle room in that, but I wanted to just go through some of the issues that we'll be addressing. We started out with a briefing on the MAIF, which is a program that sits within the Secretary's office that we wanted to get some more clarity about. So we had Dr. Tim Harrison come and give some more input about that, which was, I thought, really enlightening. And so there will be some more forthcoming work on that. We obviously want to remain focused on housing as an important piece of the work. So we'll be requesting in the near future a meeting with our Hopper colleagues for an update on what's happening within that program. We also wanted to do some work around framing up what we're calling the PACHA principles. We talk a lot about stigma, and I think part of what we want to be able to do is define what would it look like to have HIV work happen within a stigma-free environment. What does that look like? And to spend some time imagining and inviting some thoughts about what that could look like So we have a subgroup of our subcommittee that will be working on developing that. And we hope to be able to release something in advance of Zero HIV Stigma Day, which is in July. We also want to focus a little bit on workforce. I think that's been a through line through the work that we've done on PACHA for the last several years. But specifically, we want to think about some of the non-clinical workforce, right? I think we rightly focus a lot on our clinical partners, which are vital in the treatment of HIV. But we know that there takes a lot of other types of folks in the work to be able to do HIV prevention and treatment well. And we don't necessarily focus as much on that part of the system. And, you know, just speaking from personal experience with some of the leadership transitions we've had in the health department in Georgia, those are really vital conversations. So we look forward to really thinking through how do we build a better pipeline, a better bench of leaders to kind of take leadership within public health departments. So that'll be something that we focus on. What else? So that's a flavor. Obviously, the National PrEP program is also a priority for our subcommittee as well. Specifically, we want to make sure that we have equity baked into all of that. And so that's something we'll also be spending some time talking about. So those are just a couple of the domains that we'll be talking about over the next several months. So Raffaele, I don't know if you want to add anything.
No, you said it all. Thank you.
That's my brief report.
Questions or comments for Raphael or Justin in the subcommittee?
I have one. Just wanted to echo and share my appreciation for the focus on the labor force and the non-clinical support that's required as we move forward toward ending the HIV epidemic. One of the remarks I made to CDC's presentation yesterday from Dr. Fanfare was through the EHE NOFO PS 2010, how well they were able to bolster sexual health clinics in a mighty way that are, you know, really helping to forge new ways of these very vital clinic spaces and operating differently. And one of them was how much service navigation support through community health workers, case managers, navigator type of positions in those spaces. So I just thought that was intriguing. And the more we can talk about the labor force in that way, what's required to really undergird and support the foundation as we move forward. It's not solely about the biomedical, but the other supports that are also needed. So certainly as we talk about a national PrEP campaign or program.
I think one other thing, just to put a finer point on it, I think it's also important to something that we'll be talking about is really the importance of organizations and CBOs that are led by people from the communities in which they are embedded. I think, you know, going to La Clinica and to us helping us yesterday and just really seeing the excellent work that they were doing, it really, again, showed the importance and the value and the, you know, sort of centrality of these types of organizations to our movement and the importance of showing when you resource these organizations what they can actually do. And so that's obviously something that we're laser focused on and super excited to kind of drill down more into. So didn't want to leave the table without mentioning that.
Leo.
I'd just like to add on to that. One of the things I was most impressed with yesterday with Us Helping Us, or the day before rather, with Us Helping Us, was the pipeline program that they have for transgender and gender nonconforming youth. And I think as we think about the work that we're doing with the workforce, I think it's important for us to hear more about innovative models that are being employed across the country, you know, to increase the workforce of those who look like the community in which they're serving. I also wanted to raise up that recently in Los Angeles, we had an HIV workforce summit, thinking about how we can really pour back into all of our providers and healthcare workers who are doing this work every day, you know, particularly after the last 3 years that we've all had with COVID and monkeypox. And there was a focus on self-care as well, and a focus on just ensuring that there's opportunities for networking and opportunities, again, for us to pour back into each other. So I think one challenge that I would make to everyone, even those who are virtual and here in person, is if there are models for HIV workforce development or things that are working well in your program, to send those to us as we kind of work through our work that we're doing in the committee. Thank you.
And I think the other thing to raise up is I think it's so important that we also think about sustainability of those pipeline programs from the start. One of the things that we heard in our visit to Us Helping Us is that this really phenomenal program that was specifically focused on trans and gender nonconforming folks to bring them into the public health workforce was ending. We don't know why that was happening, and it's not a federal program. I think it's a program of the DC. I'm not sure kind of who funds it, but I think again, what we saw was that this was a program that brought folks with lived experience into the workforce, and that's exactly what we need. And so, trying to think through that, we figure out how do we sustain those types of programs over the long term, so that's all something that we start thinking about from the start. So that's the other thing I wanted to add. But I don't think other subcommittee members have anything to add. We'll turn it back to the chair.
Yeah, and just, I think continuing that, this piece of supporting the non-clinical workforce is incredibly important. And it isn't just at the time that you need it, right? I think as we hear about MPOX, for example, and just impressing upon the governmental public health folks out there, the importance of these sort of relationships and funding of our community-based organizations to be close to the community, in the community, is incredibly important. And certainly as a health professional, sort of my disappointment in MPOC's response was, it feels like we had to learn this lesson again about the importance of being in community, having community lead in this space, and for our sort of role to be, supporting and following their lead when they are connected to community, serving community, know how to do this. And so the workforce piece, I think, is incredibly important, both for governmental public health and the community-based organizations. And there can't be any daylight in between that. I know we all need resources. So I suspect this will be an ongoing, this needs to be not only an ongoing conversation, but work that we think about. How can we improve the situation?
Just to add to that, I think I just want to take a moment of personal privilege to thank Dr. Daskalakis for his efforts in the MPOX response and really lifting up the importance of partnerships with community-based organizations. I think that was sort of the secret sauce of success for the effort that we had in Atlanta. The work is not done, but I think it shows that when you actually activate those organizations, it has tremendous public health benefit. And so thank you, Dr. Daskalakis, for really kind of pushing that and making sure that that was a message that was amplified. So I just wanted to thank you for that.
Okay, well, we should move on since we are a few minutes behind, but I'll turn it over to my colleague, Marlene, for the introductions.
Absolutely. And this morning we have some additional updates from our important federal partners from their various perspectives. And we will begin with our important partner who really needs no introduction, but I'm going to do it anyway. Harold Phillips is the director of the White House Office of National AIDS Policy, ONAP. In this position, he leads the effort to set the administration's domestic HIV/AIDS priorities. This includes monitoring and implementing the National HIV/AIDS Strategy, consulting with the Office of Management and Budget, coordinating with others on the Domestic Policy Council, the National Security Council, and the Office of Global AIDS Coordinator to ensure that America's response to the HIV epidemic is accelerated, comprehensive, and reflective of the lived experience of those at risk of and living with HIV. So, Director Phillips, I will turn it over to you.
Thank you, Madam Chair. Good morning, everyone. And thank you thank you, PACHA, for the opportunity to speak to you twice during this convening. And I'm going to give an update on ONAP and in-house implementation and priorities. But I also want to say, just to reiterate, the appreciation for you all taking a close look at the slides that I presented yesterday and the consideration of where we are with molecular HIV surveillance and cluster detection and response, and the work that CDC has put forward as they talk about additional steps they will take to protect that data and how we use it in our response. As I do not take this work lightly, as many of you all know. It was Saturday when I got a phone call from a friend who said that a Black gay male friend of his in Charlottesville, Virginia, was in the hospital and on a ventilator. And when I got home last night after our meeting and our very long day and several Kentucky mules, I checked in to see how his friend Chris was doing. And what he told me was that Chris had been diagnosed with some sort of encephalopathy that I can't even say, some swelling in the brain, I believe, Dr. Stewart, that would be, and pneumonia. And as we continued the conversation, I realized Chris has HIV, doesn't he? It's untreated. And he said, absolutely. And I said, and with this diagnosis, this means for a number of years. And he said, yes. He's had to call his mother in Memphis to come to meet him in Virginia. His sister now knows, so he's had to disclose. He's had to deal with the shame of that. And he has an infectious disease doctor in Charlottesville in the hospital that is exploring something called the Ryan White program that might be able to help him when he moves to Memphis with no job to live with his mother. So as we think about molecular surveillance and we think about those who don't have the privilege about knowing about our system, you need to think about people like Chris, who's now getting ready to face all of this. And if we had been able to find him earlier and let him know that there was a system out there that could have helped him, he wouldn't be in this situation. He's off the ventilator, but now we face all the rest of this. And luckily, his friend knew someone who can explore who should be his Ryan White doctor in the city of Memphis. We thought the world was going to fall when we shifted to names reporting, but we found a way to do it respectfully and respecting the rights and dignity of people living with HIV. And I feel like we can do the same with molecular HIV surveillance and cluster detection. So I look forward to the ongoing conversations that we're going to have about how we continue to do this and get it right, because people need to know that we're here. I'm going to talk about the president's budget for 2024, ONAP updates, and the priorities, and leave some time, hopefully have some time for discussion as well. So with the president's budget proposal, as we have it, it continues to express the president and the administration's priorities for how we get some things done in our country. And that includes ending the HIV epidemic. And the increases that are proposed within that budget are also on the screen for the agencies. You will note that this mirrors the president's budget request for last year. Also note, we did not get everything we asked for. And that is an issue in that you heard yesterday from the federal partners about some of the successes that we've had when it comes to EHE and how they are applying the use of those funds. But without getting the needed investment in EHE, we are going to have difficulty meeting our 2025 and our 2030 goals. Now, we're going to spend some time this year looking at that data very closely and looking at the model and trying to figure out what this means. It's not only the lack of the financial investment, but also COVID has also, hit hard and caused a lot of delays, which you all have heard and talked about. But at the same time, we have a good story to tell. Some of you might have missed it yesterday when CDC said that Harris County had met its linkage to care goals for 2025 already. So, and that there were a couple of other jurisdictions that are meeting similar goals too. You also heard Ryan White talk about how they have exceeded some of their goals too. So we have a good story to tell about how we've been using these funds, but we also need to make sure that we educate those who are in decision-making positions about the need to invest heavily in EHE. The budget also proposes a PrEP delivery program to advance equitable access to PrEP, including PrEP at no cost, eliminating costs for enabling services, and establishing a provider network in underserved communities. This would be our national PrEP program. So it was proposed last year. We did not get that. We currently do not have a national PrEP program, nor do we have the authority to have a national PrEP program. What we do have, especially as Carl talked about FY23, is some directives about things that can be done to accelerate PrEP access and address the disparities in PrEP access. And CDC will do that and has proposed some things that are part of their FY23 spend plan, but we really need everyone to get behind doing the work to help ensure that we get funding for a national PrEP program, for which at this date, as I stand here, we do not have. Also, there are some directives in terms of Medicaid and CHIP and beneficiaries, and also looking at sort of the guardrails that have been put in place that create barriers to PrEP access, and so eliminating those. So there's language in that as well. The budget also talks about sort of the cost savings if these two things were to happen when it comes to all of this. Other highlights of the budget include the inclusion of a hepatitis C elimination program, which will also be helpful for us, increases in HOPWA, DASH, Title X, community harm reduction, and engagement initiatives at SAMHSA, and also the language, I think that also got mentioned yesterday about modernizing the language that for eligibility to use part of your funds for the SAMHSA HIV set-aside as part of the block grant program. So some things that also I wanted to talk about. So 58 days ago, the infant feeding guidelines were released, and we did some work to push that the new guidelines out, not only to our Ryan White providers, but also to Title X clinics, but also to WIC programs, and we'll continue to do that work. This was also mentioned in public comment, so if PACHA or other members of the public have other ideas for where we need to sort of distribute the guidelines and ensure this happens. It was also mentioned at the clinical conference as well. So we've done, in 58 days, I think we've done a great job in sort of spreading it out, but if there's more work to be done, definitely please let us know. We also worked with the Administration for Children and Families and Child Welfare programs to also ensure they were aware of these new guidelines as well. Peter is here. Hi, Peter. And Peter's going to talk about the FDA blood donation and individual risk assessment and where FDA is on that, so I won't cover that. And Lee talked about CMS and the work that has been happening there with the coverage determination and the public comment period. The Defense Department also rolled out additional information about PrEP on their website. And also there has been additional articles and toolkits put out in their sort of lane when it comes to rolling out access to PrEP as well. And the Justice Department just released 2021 data reporting on people with HIV in state and federal correctional facilities. So again, thinking about sort of that whole of government response when it comes to our HIV work. Also wanted to state that our business coalition, which U.S. Business Action to End HIV, which launched on World AIDS Day, is off and rolling and doing some, I think, incredible work already, sort of bringing attention to these issues among the private sector, and them really thinking about what they can do and how they can leverage support that is helpful. A couple of things that I will note in addition to our virtual summit that we're going to have on April 20th and bringing together members of the Health Action Alliance, along with companies in the National LGBTQ Chamber of Commerce. We are also, Walmart, which is a partner, launched their training for 170,000 of their pharmacists nationwide, the first 5 training modules, which cover HIV testing, PEP and PrEP, launched on March 3rd. And Walgreens also announced in partnership with Uber and DoorDash that anyone who lives within 15 miles of a Walgreens and is unable to pick up their prescription, they will work with Uber and DoorDash to have those prescriptions delivered. So the partnership is really looking at some of those things, and we expect more to come as a result of that. They are also looking at their own policies internally, as well, thinking about stigma, discrimination, and also looking at their own HR policies to ensure that there is access to PrEP without copay as well, or cost sharing. So lots of work still happening within that space with that cohort. We're also doing some work in conjunction with retail pharmacies and the American Pharmacists Association to look at expanding scopes of practice at the state level. I'm happy to announce that just this weekend, Arkansas expanded pharmacists' ability for PrEP and PEP this past weekend. They're also looking at other states and sort of prioritizing that work as well as another route to expand PrEP access and address the disparity. So other things specifically that the office is working on, of course, is endemic and looking at STIs. I was happy to hear Marlene talk about some of the work that's happened under EHE with STI clinics. We did Federal Implementation Work Group presentation where Dr. Minna presented some of the work that has happened, and it's very impressive in some of our STI settings. Also thinking about, and yesterday I also learned we need to do a lot more work around explaining status neutral and what that sort of means, and people entering into our system free of stigma, but being able to access the services that are necessary, either on the prevention side or the care side, and what that looks like. Working with my colleagues in the Office of National Drug Control Policy and NIDA to address the stimulant and meth use epidemics that are also fueling our HIV rates, and ongoing conversations, as you all know, with federal and community partners on updating criminal laws. Ensuring our best practices are implemented in the science, so we stop doing the stuff that doesn't work and we pay attention to what the research tells us does work, and also working to use our data in a very effective way to tell the story of both NHOS and the EHE initiative. And as was mentioned, some of the work that we're doing with some of the other departments, we just had a meeting with the caucus to really sort of begin to map out what are some of the action steps where we need the Department of Labor to lean in, and what are those programs looking like. And so using the power of ONAP to sort of convene them, as well as PACHA, and bring them together to really think about how we influence at the federal, but also the state and local level, space for people living with HIV within those programs. We're also thinking about a housing summit at the White House for HIV housing in the spring, and just beginning work on thinking about that for May as well. But looking at those, and then also thinking about the additional investments that the administration wants to make in mental and behavioral health, and how do we make space for people living with HIV within those as well. So a lot, and all of that relates to sort of quality of life and those indicators. So I feel like we're at a place right now where we've got the strategy, we've got the implementation plan, and now we're actually really doing the work and focusing and drilling down on some of those, like quality of life. Thanks. Oh, as I sit down, two other things I just want to mention, because these are the things that keep me up at night, in addition to what you already know keeps me up at night. The Medicaid unwinding. I think we all need to be talking about this because we are at huge risk. HRSA has been doing a great job of trying to get the word out, but I think we need to be talking about it at every step of the way. As of April 1st, individuals who were in Medicaid and were not disenrolled during the pandemic, states can begin to disenroll them as of April 1st. So while we are at an all-time high for individuals being covered and having insurance coverage, we may see a dip, but we need to ensure that our people living with HIV are aware of this, they have checked their status, and that they are uninterrupted. Our worst nightmare would be folks showing up at the pharmacy to receive their medications and being told you can't get it because you've been disenrolled from Medicaid. So we need to talk about that. And then summer is coming. Dimitri's going to talk about MPOX. very worried about that as well, and sort of a resurgence, a lack of folks who didn't get their second vaccination, what this might mean as we go into summer months, 8 weeks from Pride, Black Gay Pride, all of that. So those are the things that keep me up at night, that we all should be aware of and begin talking about and pushing. Thank you.
We have time for a couple of, Laura, go ahead.
Hi, thank you. Thank you, Harold, for your presentation. I just wanted to highlight one of the things that Carl had mentioned about the Indian Health Service not receiving an increase in fiscal year 23 for HIV. And I also did see that there's a $52 million increase proposed in 24, which is great. I think we've seen year to year that there's always these very significant increases proposed, but it's very rare when IHS is allocated funds. So even just having the $5 million they have now is not very much. So I do want to ask all of the agencies to make a commitment to fund EHE to end it, of course, in tribal communities and urban Indian communities. We know that during COVID, agencies were able to transfer funds to IHS. And I think just given the many priorities in the Indian Health Service budget, we really need every agency to commit to transferring funds to IHS for this purpose, especially given there was a $100 million increase and no funding was allocated to IHS for ending EHE. So the other thing I would say is there also has been some discussion or requests, I believe, for an American and Alaska Native AETC. We know there's some funding that goes to Alaska, but that's not national. We really need a national AETC. And I'd also just add, because of this endemic of like syphilis and all these other issues going on in our communities right now, we also do need a prevention training center. So just kind of wanted to put that on your radar. I know things don't happen overnight, but just wanted to mention some of the things I'm hearing. Thank you.
Leo, your mic is on. You have a question or?
No, thank you.
No, okay.
Notice how it's Leo's mic, not Mark's.
Anyone else? Any reflection or comment for Harold? Okay.
I just want to thank Harold for all of his work and leadership. We're really fortunate to have you in this position in the White House. You understand the issues, you understand the agencies, you are committed. You have personal stake in this as well. And just thank you. These jobs can be hard, and accountability can be challenging when you're trying to be accountable for a whole federal government. But we appreciate what you do, and the things that keep you up at night, I know, are the things that keep these folks up at night as well, all of us, and we do need to work together, and we do have this common vision.
And moving on our agenda, thank you for that, John, is another man who probably needs no introduction either. He has so many hats. I think he's just going to turn into the Prince symbol or something similar. Dr. Dimitri Daskalakis currently serves as the White House National Monkeypox Response Deputy Coordinator. Prior to his appointment at the White House, Dr. D, as we affectionately refer to him, served as Director of the Division of HIV Prevention at the Centers for Disease Control, and he oversees the HIV prevention response in the U.S. Dr. D also worked in the CDC COVID-19 response as a lead in health equity, as well as head of the vaccine task force. Prior to joining CDC, Dr. D served as the New York City Department of Health's Deputy Commissioner for the Division of Disease Control, where I lovingly met him many years ago. I will turn the microphone and the floor over to Dr. Demetrius Daskalakis. You're welcome.
I sound like a frog, and my purple suit is because I'm changing my name to the unpronounceable Prince symbol. So before I get started, I just want to say It has been a great privilege to get to work at the White House, and an even greater privilege to actually confirm for you exactly how lucky you are that Harold Phillips is there. So speaking from the inside, I just have to say he is a force of nature and is a relentless advocate within government to make sure that we do end HIV and the syndemics together. And so what keeps him up at night should keep you up at night as well. So I am here as one of his sleep demons. So on to my update. I'll start off in a place that you'd expect me to start with because I've had this drumbeat going for at least a decade. Mpox is a part of a syndemic. It is part of a syndemic that includes HIV. There are epidemics that interact with each other, and that by that interaction increase their adverse effects on the health of communities that face structural, systematic, and other inequities. So I like my little drawing, which really backs up what OIDP is talking about with syndemic, which is there's something about the biology, there's something about the interaction, but that interaction is galvanized by social forces that bring these infections together in a way that creates a way larger force that directly impacts our communities. Let's talk about Mpox. Here's the story of how a syndemic unfolds. So in September 2022, an MMWR came out that showed 38% of people who were diagnosed with Mpox were also diagnosed with HIV. 41% also had a prior STI diagnosis in the year before their Mpox diagnosis. All comers, 61% were either or, the beginning of the syndemic. Now, do the infections make each other worse? The answer is yes. That same MMWR showed people with Mpox and HIV were more likely to have severe symptoms. People with Mpox and HIV were more likely to be hospitalized. And the worse their HIV was, the worse they did. Loads meant hospitalization. Lower T cell counts meant hospitalization. It didn't end there. About a month later, CDC shared the 57 most severe cases of Mpox that they'd heard about through their consultation. 82% of them were living with HIV. 72% had CD4 counts of less than 50. That's not their viral load, that's their CD4 count. I haven't seen anything like that since Bellevue in 1994. Less than 9% were on HIV medicines, and interacting with the epidemic are the social determinants of health. Systemic racism, almost 70% Black and 23% homeless. That is a syndemic. Interactions that are biological made worse by social environments that make the force of the interacting infections significantly worse. Then the international case series came out around Croy that showed the same. Individuals with lower T cells did badly. Not only that, the only deaths reported in that case series happened in individuals living with HIV with T cells less than 200. HIV prevention is addressing Mpox. HIV treatment addresses Mpox. Mpox vaccine, Mpox prevention and treatment are gateways to HIV and STI connectivity and service. So if you have a syndemic problem, the US government had to rise with a syndemic solution. And we did. We have flexibilities that were established in CDC funding, flexibilities established in HRSA, flexibilities in mental health and substance abuse, and yes, flexibilities in housing that allowed us to weave together in a status neutral syndemic fashion services that allowed us to address the needs of individuals affected by Mpox. Syndemic problems require syndemic solutions. Okay, I'm going to break script for a second. Imagine if we had a national PrEP program, how much easier this would have been. National PrEP program plus HRSA, Ryan White together, plus CDC assets and SAMHSA equals a fully realized system to address the HIV epidemic. The HIV epidemic infrastructure is what we use to control Mpox. Imagine if it were more robust. Envision a status neutral universe where it was as easy to get someone at risk for HIV a vaccine as it was to get someone who was living with HIV. Imagine if the delivery system existed in a way that was integrated for us to be able to not only deal with HIV, but to rise to the occasion as you all have. And thank you, Justin, for your words, but you all did it. rose to the occasion. We just gave you the green light to do it. Let's give the green light more. So now the soapbox is gone, and on to my update of Mpox. So I want to give you an overview of where we are, as well as some really interesting new ways of looking at data. So as of yesterday night, there were 30,286 cases of Mpox reported in the U.S. and 38 total deaths. Watch this space. You will learn more about the deaths soon. Information and data are coming. We also were able to launch the National Wastewater Surveillance System looking at Mpox. If you haven't seen it, it's available every week, updated every week on the CDC website. And here's what we're seeing. We have one site with intermittent detection as of March 29th. That's in Dallas. And another site with consistent detection, which is in Southern Virginia. 2 sites in the country. So we continue to see progress. We're learning how to use this tool. We still don't know how, but it is really telling us that we still have transmission. There's still Mpox activity, but that it is slowly shutting down. And that's what an epidemic curve looks like. We still have 1 case reported per day. We're not out of the woods. As Harold said, we need to get the job done from the perspective of getting vaccine, treatment, and testing resources to people who need them so we can prevent an outbreak in the future or continuation of this one. This has been very stable for a very long time. The majority of cases that we see are in men, mainly cisgender, mostly transmitted by male-to-male sexual contact. Cisgender women represent about 3%, trans men a little less than about 0.2%, trans women a little less than 1%, and individuals with other gender identities 0.8%. You can see that the majority of cases are in folks who are younger. The race ethnicity observations that we've had for the last several months continue. About 60% of the cases, though there are fewer and fewer cases, continue to be in Black and Latino individuals. So we continue to see a gulf in terms of equity from the perspective of who's getting Mpox and who is actually vaccinated. So speaking of that, where we are with vaccine, we have 1.2 million doses administered in the U.S. to date. Thank you all for the work. It is really on your backs and really the messages that you've amplified that we were able to do this. But as I like to say, and as Harold said, the job is not done. You can see that our vaccination has trailed off. First and second doses continue to trail behind. This is a view by race and ethnicity. And you can see that we see the same disparity. Most of the doses have gone in white arms, despite the fact that most of the cases are in Black and Latino individuals. This is not an official U.S. government slide. I stole it from HRC, but I really like the way that they showed it. So this is a bar graph that shows the proportion of cases that are based on race ethnicity. Keep your eyes on the light blue. That represents Black or African American individuals. Now let's add the vaccines. Bars don't match. So though they are close to representation in terms of what we see in the population, percentage of population who are Black or Latino, we need to reach equity, which is not equality, equity, which means that our vaccine effort needs to at least approximate how the cases are distributed. More work needs to be done. And we've really gotten a lot of feedback through a lot of sources. This is a confidence report from CDC. Watch this space. There's another coming that really tells us what we need to do in terms of our marching orders to get vaccine to people in a way that they appreciate. And I won't go through it, but that involves transparency and really responding to what people are concerned about and also answering their questions in a way that they understand, which has really been our voyage since we got the details of the confidence report, as well as our feedback from our workshop that represents really the community that are overrepresented. Shout out to KAs for all that work there, really giving us a glimpse into the individual level feedback that we need to make sure that we can accelerate and nuance our response. So I go back to the finish the job. So we know the vaccine is safe and effective. We know it prevents Mpox, it prevents hospitalizations and some symptoms of disease. Summer is coming, and I am also kept up at night by the fact that it is. So we need to keep on working, leveraging our HIV resources, the new crisis coag that's out there to really accelerate the work we're doing. We are currently working on setting up a meeting with all of the amazing agencies, HHS and non-HHS, that worked to create the flexibilities so that we can remind people that they still exist, even with the end of the public health emergency, so that we can continue to use that amazing infrastructure to get the work done. So I have a couple of additional updates, all breaking news, but thought I would share. So tomorrow's a big day for MPOX. We have our MPOX research gathering. If you are not coming, that is okay. I forgive you. But 500 of your friends are. But what I advise is go on to the HIV.gov website. Shout out to HIV.gov. So thank you. And look at the videos. They really talk about various domains of research as well as surveillance. They're really fun to watch and you'll learn so much. They go along with the fact that we've released another updated inventory of all the U.S. government MPOX related work that's been done to date and that continues. Just a quick stop here. The MPOX research response has been historic. We were able to put out priorities during an outbreak and then give a complete accounting of what work is happening based on the community's requests that we do. So really a great pattern for other outbreaks in the future. Also, there's a new resource on CDC, which is really reflecting what Harold and I are losing sleep about, which is a resource really for LGBT folks as Pride season approaches about what they can do to stay healthy. MPOX is one of many things in there. It includes travelers' health, HIV, STI work, and overdose prevention. Everything's in one place. Link it on your website, get the word out, tweet it. It's a one-pager with all the resources people need. And if you can't find it, just email me and I will send it to you. We have a QR code, all the good things to make sure that we get it out. And then finally, spoiler alert, coming very soon, in fact, imminently, we're going to be releasing vaccination rates by state and jurisdiction publicly. Along with the state and the jurisdictional release of vaccination rate, we'll also be releasing at CDC modeling that shows that there is a linear relationship between vaccine and the likelihood of preventing any outbreak of MPOX in your jurisdiction. And there is a threshold. If you are less than 30% vaccinated, your chances for a large outbreak are much significantly increased. That's the line that goes straight up, and the dot is 30%. Call to action. We don't only have an idea of let's vaccinate more people, but imminently we'll be able to give you some really good guardrails about what that means. Though the modeling data is coming soon, spoiler alert, it's already in the videos. So if you were to watch the vaccine video, you can hear all about the model before it's actually released on the CDC website. Not to make you go to that website, but boy, those videos are great. And then that's it. So I wanted to just thank you for your time. I think I'm still on time, and I will defer back to Marlene. Thank you.
Thank you so much, Dimitri. You are on time. We are not. I just wanted to acknowledge another PACHA member has now joined us. Welcome, Dr. Darrell Wheeler. It is so good to see you. And I will take one comment or question so we can sort of make up for some time. So go ahead, Dr. Sag.
Yeah, so the comment is just amazing response. And I think, especially with all the negative press that we hear about COVID response initially as the outbreak happened, this is the opposite. So congratulations on that. And I guess my question was addressed in your penultimate slide, but I was having trouble placing why summertime was a concern. I guess we're channeling Martha Reeves and the Vandellas that this is summertime is here and it's time for dancing in the streets. Is that the idea?
Yes, I'll refer you to one of our amazing White House HHS collaborative videos where we say that your vaccine is a bridge to more fun, more sex, more fun over the summer. So I think that it's just, we know that as gatherings are more likely to happen, and sometimes sex and other close body skin to skin interactions are part of it. Right now is the time. Try to vaccinate so that we can prevent them and so that we continue to let the good times roll, as it were, for the summer.
Thank you. And we will move.
It says, or under the board.
Or under the board. That's funny. we're going to try to go through our next couple of presentations before we take a break. A man who will speak to us next has been doing phenomenal work for many years. So happy to have Dr. Peter Marks here. He is the director for the Center for Biologics Evaluation and Research at the U.S. Food and Drug Administration, and he's here to speak with us today about the update regarding the blood donor policy. Dr. Marks.
Great. Thanks very much. Really appreciate it. And it's great to see all of the incredible work that's being done by others. I'll give you an update on where we have come with our blood donor deferral policy to reduce the risk of HIV. We released a draft guidance that in January, moving towards an individual risk assessment policy. And that draft is currently open for comment. That comment period closes tomorrow, and we're hoping to move that forward. I'll tell you in a moment. But I just want to tell you how we got there. Moving this forward has been a journey since 2014. With first to shorter deferral intervals, and now hopefully towards an individual risk assessment. We're moving in this direction based on several lines of evidence. Some of this has to do with looking at global partners such as the UK and Canada that have moved to individual risk assessments. And some of it comes from data that has now come from a study that was initiated several years ago, but was conceived now back in about 2016, called the ADVANCE study, or it became known as the ADVANCE study, which is to try to develop the evidence needed to move to a relatively simple individual risk assessment. This individual risk assessment study was conducted in a number of cities across the country, all of them where there has still been a significant HIV transmission. The idea here was to look at areas where we might have donors that would be most at risk, essentially to pressure test the system. This was importantly a work that involved a collaborative effort between not just government partners, but blood collectors, community organizations, some academic institutions that put together this study and has executed it. The study was basically a simple study which involved really 2 visits, an eligibility assessment, consent to participate, and then looking at whether a blood sample, various tests from a blood sample correlated with questions, a simple questionnaire that was answered, and then having people then potentially consent to a more extensive questionnaire after that blood sample was taken. The enrollment into this study, this was a bit of a challenge because there was this thing called the COVID-19 pandemic that happened in the middle of it, which it's a testament to the organizations involved that they were able to get close to the intended enrollment of 2,000 individuals. There were 1,788 eligibility visits, which ultimately resulted in enrollment of 78% of the 2,000 person goal, which we considered adequate to get the information that we needed, particularly because we were originally only going to have 200 to 250 of these extended follow-up interviews, but we were able to fund 1,200 of them, and those turn out to be a very rich source of information. The data from that study will be posted imminently. It's another spoiler alert. Probably look in the next week or two. It's being submitted to a medical journal, a major medical journal, and it will go up on a preprint server probably in the next week or so. People have been very anxious to know the results. They are revealing, I think there's some really interesting information there with a richness of information that was very helpful. I think the public presentation will be interesting. The guidance that was issued in 2023 was an update to draft to our donor deferral, but the key pieces of this are we still will have to permanently defer people who have HIV at this time. Obviously, the people for now who have recently taken PrEP within 3 months oral PrEP or 2 years for injectable PrEP will be deferred. That is something that I know is there are some in the community who are very concerned about this because obviously it will reduce the number of people who might donate. We are going to continue to look at whether there's a group of people taking PrEP who could potentially donate. But I think we wanted to do something now as opposed to waiting for the 6 months to a year or even year and a half to get this additional data, these additional data. So this allows us to move forward. It allows us then to have our proposed deferral algorithm, which is that basically we are going to ask the same questions of everyone, and regardless of gender, and there'll be the same question of whether you have had a new sexual partner in the past 3 months, or whether you've had anal intercourse in the past 3 months. If it's anal intercourse with one partner, there's no deferral. If it's more than one partner, there would be a deferral. And I think the ability to have one set of questions that gets asked for everyone, I think, gets to, it may not be perfect yet because we still have the issue with PrEP, but I think this is getting a lot closer, and it's as good as any place across the globe right now. The few countries that don't defer for PrEP ostensibly on paper do in practice. That's because they have oral questions that are done by a physician in those smaller countries, such as Italy and Israel. So I think we're right up there now with the most advanced countries leaning into how far we can go. So docket closes tomorrow. Our folks are already taking into account the comments that have come into the docket. Some were very thoughtful comments about how best to present essentially how to avoid how to best present the questions so that we get the best responses. I think those were great, and but nothing that makes us have question about what we're doing. So we fully expect that this will be able to get finalized in the not too distant future. Obviously, that depends on our friends at the White House. It has to go through some review there, but I think we might have friends that can help us there. And I think the goal was to actually have this done in advance of Pride Month in June. So this is where we stand with this, and I'll stop there so I can take any questions and get you closer to being on time.
And I too just want to express my thanks and appreciation for your leadership on this, Dr. Marks, and your ongoing leadership and work to continue with the revisions necessary. And really want to acknowledge PACHA members around the table who really helped to lead voice into some of these revisions. We were not talking to case. So just to say, Justin and Adrian Shanker, when he was a member of PACHA, good to still see him available and around the table. Yes. Really gave voice into it. So just appreciate the engagement and sharing and working directly with PACHA, Dr. Marks. And so hope that will continue. And I guess the first comment or question is Harold.
So thank you, Peter. I just wanted to put this out here for PACHA members to so that you're aware that not only, Dr. Marks led sort of this effort, but there was this whole team when it came time for the actual rollout that was working at FDA that really were tremendous in pulling it all together in terms of the communications, the outreach, and they just did, I thought, a tremendous job and really were responsive, I think, to both the needs and the community questions that came up. Now I got Dimitri's thing going on. That came up as we were rolling this out. So thank you to all those who were behind the scenes as well at FDA for your collaboration and your work on this particular issue. Thanks.
No, thanks a lot. And I think we also owe Adrian and his colleagues a bunch of thanks, because they helped also ease the way with quite a number of federal partners. So thank you.
I just want to say on behalf of the community, I thank you, and I think we should all rise.
Now, I think our next couple of presentations before our break really begin to set the stage for our upcoming panel. The federal updates regarding what's occurring on substance use and drug overdoses. We will hear both from Dr. Grant Baldwin and Redonda Chandler. Dr. Chandler is the director of the HIV Research Program and the Healing Community Studies at the National Institute on Drug Abuse, and it's part of the National Institutes of Health. As the HIV Research Program Director, she's responsible for the development, planning, and coordination of high-priority research on HIV/AIDS and drug use within NIDA and across NIH institutes. Dr. Baldwin is the Director of the Division of Overdose Prevention at CDC's National Center for Injury Prevention and Control. He leads the division in monitoring trends in the drug overdose epidemic and other emerging drug threats, identifying and scaling up prevention activities to address the evolving drug crises, and supporting local drug-free community coalitions. I will ask the two of them to simply present one behind the other, and then we'll take questions for each of them at the end of Dr. Chandler's presentation. But we will begin in order with Dr. Baldwin.
Great, thank you so much. Good morning, everybody. And I think you have my slides there, or I can share my screen, whatever you would prefer is fine. I'm going to be talking a little bit about the drug overdose burden. And then, yes, okay, they're coming up now. I'll talk about the drug overdose burden, the latest data, and what does it mean for prevention. And then Redonda will follow up me and really drill in on what some of the known effective strategies are right now. Next slide. So here's where we stand with the drug crisis. Probably familiar to you, we've lost 107,000 of our fellow Americans, driven principally by the three things listed in the bottom left corner of the slide. The continued increased burden associated with illicitly manufactured fentanyl. I can't underscore that point enough, and I'll drive it home throughout my portion of the presentation. Challenges posed by the COVID-19 pandemic, whether it was social isolation or disruption of services. And then this important note around co-involvement, the polysubstance crisis. The couple of graphs that you see on the right are from a Suitors report from a couple of years ago that show increases in trends across a number of drug classes, but note that trends without co-involvement that did not in fact involve synthetic opioids, excluding methadone for prescription drugs, for prescription opioids, and for heroin went down. The story here is really around illicitly manufactured fentanyl and resurgent methamphetamines. Next slide. So the drug overdose crisis was worsening prior to the pandemic, but it has increased markedly since then. You see on the left, trends in all drug overdoses have increased 33% just since the pandemic began, and trends for synthetic opioids, excluding methadone, again, the class that includes fentanyl, have gone up 70%. Notice a beginning of a plateau, but these are provisional data that get filled in further by our colleagues at the National Center for Health Statistics. So I think I'm confident in saying that I think we may be beginning to plateau, but it's too early, and we would be plateauing at a level that's unacceptable to all of us. Next slide. So I like to have when I do presentations like this, to give a larger historical perspective about the drug trends. You know, we were raising the alarm in the early 2000s when we were talking about around 20,000 drug overdose deaths, and you heard the number of 107,000. So this graph, and I don't have time to drill into great detail on it, shows the trends that show drug overdoses increase first for prescription opioids, then for heroin, and then this skyrocketing, these the light blue bars here for synthetic opioids, excluding methadone. And note the significant increase in the percentage of deaths that involve any opioid. They've increased from just shy of 50% to 75%. Next slide. So this is the cumulative number of drug overdose deaths. So note, and it's obviously for every drug overdose death, there's a personal story and a family impacted by that tragedy. But if we just simply look at the numbers, we've eclipsed 1 million drug overdose deaths in our country since just 1999, and an acceleration of those deaths, especially since 2013, when illicitly manufactured fentanyl was on board. And you see on the right-hand slide of the side of the slide the specific waves I spoke about on the last slide. Next slide. This looks at a historical trends just in opioid-involved drug overdose deaths. And again, I'm looking here showing the decrease in the percent of drug overdose deaths that involve both prescription opioids and heroin since 2013. It really is that story of fentanyl that is really the story of the moment. Next slide. I have created some version of this graph for many years. This is the first time I've created where all 50 states have increases in their drug overdose death rate between 2019 and 2021. West Virginia had the highest rates in both time points, and rates in Alaska, Mississippi, and Louisiana doubled. Remarkably, 12 states increased over 75%, and 40 states increased over 25%. Again, for some historical context, in 1999, the overall drug overdose death rate for our country was 6.1 per 100,000, and now it's 32.4. Next slide. Looking very specifically at cocaine-involved overdose deaths have gone up markedly as well since 2013. The light red bars show cocaine deaths that didn't involve any opioid, and the darker blue are those that involved opioids. So you can see the light red bars have gone up a little bit, but it's really this co-involvement story that is the story of the moment. You can see the percentage of cocaine-involved deaths with opioids increased from 57% in 2013 to 80%, and the lion's share of those involve fentanyl. Next slide. A similar story on psychostimulants with abuse potential, again, methamphetamines largely. Note the increase in deaths that involved an opioid increased from 37% to 66%. But unlike the last slide, note that the lighter yellow shaded bars here have gone up independent of opioid co-involvement. So deaths with opioids have gone up, but deaths without opioids have also gone up. Next slide. It was talked a little bit about earlier with other health situations, but I wanted to recognize the increased health disparities that we need to be attentive to as we do our work. And frankly, when we started really focusing in on the problem here at CDC, it was a white, rural, male issue, and now it's an everyone, everywhere problem. But the increases in recent years have disproportionately impacted racial and ethnic minorities. So you see the increase among non-Hispanic Blacks and the huge increase among American Indians and Alaska Native populations. So every race and ethnicity has gone up, but fairly significant increases in the two categories I just mentioned. Next slide. So this is my elephant in the room slide. I pulled this data from the latest provisional estimate. So 68% of all drug overdose deaths and 90%, so 9 out of 10 opioid-involved deaths include fentanyl. Next slide. So one of the things that's striking, and this is the data from a recent DEA alert that showed that the percentage of pills, counterfeit pills seized by DEA, by our law enforcement community, that contained a lethal dose, which you see, this is a great picture from DEA on what 2 milligrams of fentanyl looks like, literally fitting on the end of a pencil, has increased from 40% to 60%. Obviously, what constitutes a lethal dose depends a little bit about a person's body size, tolerance, and their past usage, but it's a remarkably small amount, and the supply has gotten much more lethal over time. Next slide. So this just reinforces the point around drug seizure data showing the huge increase in fentanyl-related seizures beginning around 2014. Next slide. Similarly, showing trends in fentanyl pills and powder seizures by quarter, again, showing a huge exponential increase by weight and count over time. Next slide. So one of the things that I want to reinforce to the group is this notion that, if you think historically about a continuum of substance use from no use, initiation, experimental use, occasional and social use, more regular use, developing problematic use, and ultimately developing what would constitute a DSM-5 substance use disorder, that your risk of having really bad outcomes increased with across this continuum. But with a market, and we know this because of adolescent deaths doubling between 2019 and 2021 as a specific example, your risk of very bad outcomes increases just simply upon initiation. So it's that calculus that has changed remarkably. Next slide. These are some other factors at play. Obviously, it's synthetic and is made with precursor chemicals that are widely available in China and India and shipped to the cartels in Mexico. It's, of course, sought after because of its potency and more available now than ever, not just beyond its initial footprint in the Northeast and Midwest. It's easier to traffic because it's so compact. You saw that 2 milligram dosage. Historically, trends in trafficking through the mail and other package delivery services were rampant. And the other point from a narconomics perspective is highly profitable. It's up to 20 times more profitable to heroin, and a kilogram of fentanyl at that profit margin is cut into 16 to 24 kilograms of other street products, extending the supply dramatically. So unlike a kilogram of fentanyl, which would generate potentially a profit, and this is a little bit dated, of around $80,000 at about $5,000 to purchase, a kilogram of fentanyl generates a profit of around $1.8 million. I don't have time to talk about xylazine, but that's another emerging threat for us. Next slide. So I wanted to, sort of juxtapose where we stand with drug overdose deaths with, where we are with use and new initiations. The story here is really around, we have seen an increase in past year illicit drug use in marijuana. So cannabis has increased as legalization has occurred, but trends, and I couldn't do some comparisons because of the changes in NISDA data collection strategies. Trends are largely flat or declining across other drug classes. Next slide. Trying to make the connection here on the association between substance use and mental illness. So not surprisingly, substance use is greater for individuals who have any mental illness, and even greater still for individuals who have a serious mental illness. So as we do our work across the continuum of care and we think about where to invest our resources, we need to be attentive to these comorbidities. Next slide. Here's data that you're probably familiar with, the dose-response relationship between a person's experience of adverse childhood experiences and their risk of subsequent substance use increases across all the categories listed on the x-axis of this slide. Next slide. Just a quote I love from a recent book I read from Leanna Wen, former commissioner of the Baltimore Health Department and executive director of Planned Parenthood. We don't need to find common ground. We need to find higher ground that addresses common interest. Next slide. So just a couple more slides from me. This is just an overview of where we think we should be investing our time and attention and resources, not just at CDC, but across the federal landscape. So addressing ACEs, supporting harm reduction and the provision and use of naloxone. Obviously, we're at a banner moment with naloxone becoming OTC, expanding access to and provision of treatment for substance use disorder, as well as retention in treatment, including the wraparound services and supports that we all know are so essential for that retention, intervening early with persons at the highest risk of overdose, so attending to disproportionately impacted populations, and really doing a better job of understanding where those emerging drug threats are. Next slide. This is the overdose prevention strategy that was released in 2021 in October. What's remarkable about this is that you see as a headline a focus on harm reduction, which is so critical because of the fentanyl market, but across the continuum of where we need to be doing our work are all represented across the HHS overdose prevention strategy, but I wanted to call out specifically harm reduction. Next slide. I think this is going to be my final slide. I wanted to talk a little bit about what we're doing at CDC at a very macro level. You can see our guiding principles with a focus on things like health equity and understanding underlying risk factors, of course, focusing on evidence-based action. But what we're doing specifically, monitoring and analyzing and communicating trends. We have large-scale systems, which I don't have time to talk about, like Suitors that looks at circumstances and context of drug overdose deaths. building state, tribal, local, and territorial capacity. We have a new cooperative agreement, 2 new cooperative agreements actually, that are 5-year long that really pivot what we're doing to focus on the challenges of the moment, supporting providers, health systems, payers, and employers, both to, you're probably familiar with the 2022 CDC clinical practice guidelines for prescribing opioids, make sure pain is properly treated, but also we're making a huge investment on linkage to care, greater partnerships between public safety and community organizations. The overdose response strategy is a great example of this. And finally, raising awareness and reducing stigma, so critical to the work that we do. We have a Stop Overdose campaign and the RX awareness campaign that is absolutely fabulous. So with that, let me pause and turn it over to Rodana to give her portion of our presentation.
Rodana, the floor is yours.
Oh, I'm sorry.
No, go ahead. The floor is yours.
Thank you, Grant, and thank you all so much for inviting me to be here today. I have taken the opportunity to listen online to your meeting yesterday and this morning, and have thought a million times over about how I would revise this slide deck or what I would add or change because of all of the exciting things that you all are talking about that really have direct applicability or could be applied to the intersection between substance use, the overdose crisis, and HIV. Next slide. So this just briefly has 3 broad areas I'm going to cover. Grant did a great job of doing the lay of the land of overdose fatalities. And so I want to talk about the intersection of overdose and HIV, evidence-based practices that can address both overdose and HIV, and then integration of care. Next slide. So this is just a reminder of the data that was just presented with regard to where we are in terms of the overdose crisis and the contribution of fentanyl. I want to remind everyone of something that I'm sure you're already aware of, which is that everyone that is at high risk of an overdose fatality is also either living with or at high risk for HIV. Next slide. So this is data from a study in New York City where they looked at overdose deaths among people who are living with HIV from 2007 to 2017. And during that decade, 821 people lost their lives that were in the New York City HIV registry, with the cause of death listed as an overdose fatality on the death certificate. You can see that 821 of them on the left were an accidental overdose, whereas on the right-hand side, you can see that these individuals, these 49 individuals, were listed as intentional or a suicide. And what's interesting to me is that 98% of them were linked in care and 75% of them were retained in care in the month prior to their overdose death, which means that HIV treatment programs have a tremendous opportunity to be able to support people and deliver effective interventions to reduce their overdose risk. Next slide. So this is just data representing the fact that counties are very vulnerable to the rapid spread of HIV and other associated infections with injection drug use, and we've had outbreaks all over the country, and you can see many of those here. Next slide. And then these are data from West Virginia, from a single county in West Virginia where they have experienced an HIV outbreak. And you can see that this has occurred among people who are injecting drugs, and you see how rapidly HIV was transmitted among this group of individuals. But also what I wanted to note, and what Brad pointed out, is that across part of this same time period, the age-adjusted rates of opioid-related overdose deaths was 81.4 per 100,000 individuals, making it the highest in the nation at the time. Next slide. And then you all have spent a lot of time talking about social determinants of health, so I know you're very well aware of those and the importance of addressing social determinants of health is a comprehensive approach to dealing with HIV, but also it's a comprehensive approach to dealing with risk of overdose as well as substance use disorders. This is a study that estimated the global contribution of unstable housing to the transmission of both HIV and HCV infection. And it adds to the growing evidence base about the importance and the need to really address social determinants of health. The model predicts that unstable housing will contribute to almost 8% of new HIV infections and over 11% of new HCV infections worldwide among people who inject drugs across the 2020s. And you can see that transmission is different depending on region as well as different depending on nation. And unfortunately, the United States has some of the highest attributable risk because of the lack of availability of housing. Next slide. We do have evidence-based practices that we know significantly reduce the risk of opioid overdose fatality. And the first tool we have in our toolkit is naloxone. Naloxone is the medication that can be administered in numerous ways, including intranasally, that blocks opioid mu receptors in the brain. It does this very rapidly. We have had increasing challenges with naloxone because of fentanyl and other synthetics that are present in the drug supply. And it sometimes takes multiple administrations in order to be effective. But regardless of that, naloxone still works. It is extremely effective. The formulation now, which is the intranasal formulation, makes it extremely easy for bystanders and other people to be able to administer naloxone and takes away some of the apprehension that someone may have about intervening. And modeling data shows that most of our states still are not distributing a sufficient supply of naloxone to be able to curb overdose fatalities. And that's especially true in rural areas. And we know that availability is not equal for everyone, and certain racial ethnic groups don't have the availability they need. Next slide. We also know that the second tool that we have has to do with medications for opioid use disorder. And the great news there is that medication for opioid use disorder serves multiple purposes. It addresses substance use. It significantly decreases overdose risk when people are taking it. And it also improves HIV outcomes. So that's like a home run for all of us. We know that there are 3 different types of MOUD. There's methadone, buprenorphine, and naltrexone. They all work in very different ways, whether it's an agonist, a partial antagonist, or a full antagonist. But overall, they reduce opioid use. When people have these medications on board, it significantly decreases their risk of an overdose fatality. And it also improves outcomes around HIV, significantly lowering the risk of HIV and HCV transmission. And it improves retention in HIV treatment. And you can see here in the slide to the right, significant increases in the impact on HIV outcomes. MOUD has been estimated to reduce HIV infections by 54% and to reduce overdose risk by 73%. Next slide. And then in this slide, this is a meta-analysis that looked at the impact of MOUD on ART outcomes for people who live with HIV. There were 32 studies that were included here, and MOUD was associated with a 69% increase in the initiation on ART and a 2-fold increase in adherence, a 26% decrease in dropping out of treatment, and 45% increase in the odds of reaching and continuing to have viral suppression. So this really supports the use of MOUD as a part of comprehensive care for people who have opioid use and integrating it into good comprehensive HIV care. Next slide. Yet despite all of this evidence, MOUD coverage for people who inject drugs or people with opioid use disorder is extremely low worldwide, including within the United States. Next slide. And somehow the title got dropped when I sent this slide. I'm not sure what happened, but this is about provider stigma. And to me, this is a real heartbreaker. Stigma against people who use drugs, especially people who are injecting drugs, is a significant barrier to evidence-based care, including for HIV. This slide shows two different sets of data. It's surveys at the top done with infectious disease physicians in the US and Malaysia, and it demonstrates that providers said that they would defer the initiation of ART for people who are injecting drugs, even when their CD4 cell count was extremely low. This impacts not only the health of the individual, but it also impacts treatment as prevention efforts. And then at the bottom, you see a new paper that just came out that I read late the night before I handed in the slides, and I didn't have an opportunity to create a visual of the data, but it was looking at bias against people who inject drugs from primary care physicians who are at the front lines of being able to make PrEP available. And it showed that 32% reported explicit bias toward people who inject drugs regarding PrEP. 88% had strong implicit bias. Only 9% had no bias. And the impact this had is that if you had implicit or explicit bias, they weren't even approaching their patients about PrEP. They weren't even talking to them about it or asking them if their interest or whether or not they'd be interested in a prescription. And so when we talk about wanting to increase the use of PrEP, this is a really important target that we have. Next slide. So I apologize to Granite CDC. I didn't update this. This is opioid prescribing guidelines, which is March of 2016. And as he said in his talk, they have newer guidelines. But the third toolkit that we have is to really have safer prescribing of opioids. And I looked into the literature as I was preparing for this talk and learned that, I already knew that a large proportion of individuals living with HIV struggle with chronic pain, but the literature reports this huge range all the way from 25 up to 90%. And many of those are being managed with the prescription of opioids. An estimate of 25 to 53% are prescribed prescription opioids to manage chronic pain. And so in terms of addressing the overdose risk for those as well as other individuals, being able to have non-addictive treatments for chronic pain is really important, and making sure that those who are being prescribed opioids are being prescribed those in a safe and effective way, because we want to be able to both manage chronic pain of this particular patient group as well as to make sure we're doing it safely. Next slide. So, to me, the good news is that there is a lot of overlap here, and harm reduction for overdose risk can really easily be integrated into HIV care. We all have the same goals. We want people to live another day, and we want people to live full and healthy lives. So we want to reduce overdose deaths. We want to address HIV and other health care needs. We want to reduce transmission risk. And we want to provide an array of services that meet people where they are. And by meeting people where they are, I mean on two levels. You want to meet people where they exist geographically, because often our services are too distally located from where people exist within their lives. And you also want to meet people where they are in terms of their preparedness for something like substance use treatment or going on ART. Sometimes it takes many touches with someone to encourage and support them into getting into the type of care that they really need. And we must reduce stigma to increase access to health and recovery services. And we have to address social determinants of health to access and retention and care. And that includes not only housing, as I showed on my earlier slide, but also transportation, because transportation needs are huge in urban areas as well as rural. Next slide. There are many ways that harm reduction approaches to dealing with overdose risk as well as substance use disorders can be integrated into HIV care. Things like syringe services, fentanyl test strips, and xylazine test strips that are just starting to appear can be distributed, naloxone along with overdose education. The broader acceptance of non-abstinence outcomes. People shouldn't have to be abstinent from their co-occurring health condition of substance use disorder in order to get good HIV care, whether it's prevention or treatment. HIV, HCV, and STI testing and treatment, wound care, PrEP, low threshold MOUD, which could be made available through integrated HIV services and HIV care programs, as well as peer and professional support specialists that can assist with things like entering into substance use treatment and also helping them in those social determinants of health and really important things like obtaining state identification that they often need as entry into key services, housing, transportation, food, etc. Next slide. And I'm almost done. So there's some key takeaways. Overdose fatalities are preventable, and we have a toolkit of evidence-based practices. People living with HIV are at high risk of overdose fatality. People at high risk of overdose death are also at high risk for HIV. We have evidence-based approaches, including that exist that can reduce overdose fatalities, that can reduce the risk of HIV and other infectious diseases, and that can assist us in getting people into HIV care and keeping them in HIV care. And harm reduction can be integrated into HIV care. Next slide. So yesterday, I was struck by you all talking about what can PACHA do? How can we help? So I developed this slide and sent it in late. You all can help both from your work as a team as well as in your individual daily jobs in calling out examples of stigma against people who inject drugs. That includes stigma in terms of our language, where you hear people talk about somebody being dirty or clean, where you hear somebody talk about people who's detoxing as opposed to someone who's going through medically assisted withdrawal. Those kinds of things are really important. You can help demand high quality healthcare that is defined by addressing substance use as well as HIV and other healthcare needs. And please consider including people, if you're not already, with living experience for substance use. And this includes people who are currently using substances on PACHA, within community advisory groups, within positions of leadership, so that we can ensure that their voices are really being heard and included in all of these response strategies. We've done this successfully at NIDA through a large community-based study that I lead called the Healing Community Study. I'd love to talk to you all about that at another time. It is very community organized. And to promote integrated care that fully addresses healthcare needs for patients. These are one patient with many needs, and an integrated single point of care gives them the highest quality of treatment, gives them the greatest outcomes, as well as reducing burden for them. And then we need ongoing research, of course, to be able to aid communities and organizations in developing and delivering tailored responses to address the opioid risk, substance use, and HIV and the needs of their communities. And that's it. Next slide, and I'm done.
Thank you again, both to Dr. Baldwin and Dr. Chandler for sharing some very stunning data and information. And I know that we're going to hear a lot next from our panel around how this looks, operates, and gets responded to in communities. But are there questions or comments from around the table? Go ahead, Laura.
Thank you. I just wanted to thank the presenters for that presentation and highlighting the rates of overdoses in American and Alaska Native communities. I know our tribal communities are really concerned about that. There is a tribal response being organized right now. We are hosting a national tribal opioid summit with the we're going to basically have recommendations coming out of that for federal agencies at the end of that. And that is August 22nd to 24th at Tulalip, Washington. So just wanted to share that with CDC in particular. We're also looking at a model based out of Iceland that has been able to address the opioid crisis. It looks more upstream and looks at protective factors like cultural community factors that actually can reduce opioids. So just wanted to share that.
Yeah, thanks for that. I really appreciate it. I didn't have a chance to mention the tribal investments that CDC is making as well, which are significant. We've also just recently hired a health equity officer, and everything that we're doing right now in the drug overdose crisis is infused with a health equity lens. I did want to, since I have the mic again, I wanted to apologize because of the time delay, I have a hard stop right at 11 o'clock. So I'm going to have to drop off. I apologize. I really wish I could have managed my calendar better, but thank you for the opportunity to include CDC. And I appreciate all of your leadership. Happy to do follow up afterwards.
Thank you. Appreciate your time, Dr. Baldwin. Thank you. Dr. Stewart.
I just wanted to make a quick comment and thank you so much for really elevating and highlighting the importance of addressing implicit bias within the provider community. It's really important that we address this because we cannot get individuals in the door and get them the care that they need unless we are all, that we all recognize the biases that we all have. So I just wanted to thank you for really elevating and highlighting the importance of that. Thank you.
Yeah, I mean, it's absolutely critical. It's critical for substance use care, and it's critical for HIV care because it's still existing. In the United States, we still have people that are not getting immediate access to antiretroviral therapy if they are HIV positive because you've got providers that are biased against people who are using or injecting drugs and think they won't take it, and so they don't start them on it, and they don't even give them the opportunity to know about PrEP. So it's a really, really important barrier.
And Justin, your tent goes up and down, but I'll have you. But I'll have you actually be the last comment. Dr. Wheeler, I'll have you sort of mold that into the panel conversation you will be facilitating. So go ahead, Justin.
No, these were fabulous presentations. As someone that doesn't work primarily in the substance use world, this was really just a great backgrounder. And I wanted to just give a shout out to Dr. Baldwin for giving me a new vocabulary word of narcoeconomics. So that is the word of the day. So.
Oh, please. Yes. Go ahead, Vincent.
Thank you very much. So both presentations were fantastic. Really enjoyed them. I just wanted to make a comment and then maybe ask a question. So the comment is that I really appreciate the focus on naloxone. And in my view, I think we need to think about novel ways of delivering naloxone to communities and sort of making it much more accessible. My interest is really on the 37 million people, that's the last time I checked, who actually meet criteria for having a substance use disorder in our country and who are not in care. And to me, that represents an opportunity to borrow from HIV. And there have been many ways that HIV has been really innovative. And I want to say thank you for the removal of the additional educational requirements for getting an X waiver as a nurse practitioner. I think when I first got my X waiver, that was additional work to get the frontline providers on the ground prescribing buprenorphine or one of the other treatments that we have. And my question is, at the School of Nursing at Duke, where I happen to serve as the dean, a small group of faculty, we've been really thinking about ways of moving from sort of overdose intervention to rapid quick start on buprenorphine. And so we've been really thinking about quick start methods, microdosing, low dosing, high dosing, and we need more guidance so that we can train the country's largest workforce, nurses, in how they can best on the spot not only save a life, but transition someone to treatment at that time, right at that point. And so I don't know, Dr. Chandra, if you have any thoughts on that or if that's something that we just don't have enough evidence.
So the preference of patients has shifted because of the presence of fentanyl. Many patients are now preferring methadone over buprenorphine because of their concerns around withdrawal and because of the different ways in which the different medications work. But in terms of microdosing, macrodosing, appropriate dosing for bup, when you are trying to initiate someone, NIDA is currently engaged in a series of studies to try to determine the best way to be able to do that. There are a lot of people out there that are doing it already. If you email me, I can send you the information for some of our colleagues that are trying very innovative strategies that they can go ahead and send you some of their best practices, even as we wait for more definitive evidence, because we realize people are coming in every day and you've got to go ahead and address their health needs and you've got to go ahead and do something for them. So just email me and then I'll put you in touch. I'll be happy to put you in touch with them. And if anybody else has questions that we didn't get answered or anything I can help you with, please let me know.
All right. Thank you so much to our panelists. Again, Dr. Chandler and Dr. Baldwin. Let's give them a round of applause. Again, we are behind schedule. We think we have opportunity to make that up during discussion and the panel. We will take a break. I am asking and strongly encouraging everyone, please take a hard 10 minutes, be back in seats, and we will be ready to begin the panel right after that. So thank you so much.
Produced by the U.S. Department of Health and Human Services.